5 years ago, it would have been inconceivable for us to think that there would have been a trial of a therapy for second-line pancreas cancer that resulted in a survival of over 12 months for all patients on trial.
Pancreatic cancer has been one of the hardest stories in oncology for a very long time. Today, for the first time in years, that story actually changed. My guest is Dr. Paul Oberstein, Director of GI Medical Oncology at NYU Langone Perlmutter Cancer Center. He spent his career treating patients with one of the toughest diseases in this field, and he was part of the global trial team behind RASolute 302, the study that just delivered the biggest pancreatic cancer news in over a decade. In patients with previously treated metastatic pancreatic cancer, a once-daily pill nearly doubled survival compared with chemotherapy. That's not incremental. That's the kind of result this field has been waiting on for a long time. We're going to talk about that, what it actually means, not the press release version. But before we get there, I want to know how he ended up choosing one of the hardest corners of oncology in the first place, and what kept him in on it on the years when the data weren't moving. This is the Moonlight Shift. Pull up a chair. Dr. Oberstein, everybody. Hi, Dr. Oberstein.
Thank you so much for having me.
Welcome to the Moonlight Shift.
Thank you.
We are so excited to have you here. It's been a very chatty ASCO. Please have a seat.
It's great to be here.
I'm so happy to have you here. How has it been post-ASCO for you?
So this has been, probably the most exciting ASCO I've ever gone to, and it's just been thrilling to talk about the data and talk about what's next.
I think it's really cool when it's ASCO weekend and you see data coming out on mainstream news as well. It's not something you see every day, but I saw like Washington Post and CNN and everybody talking about RASolute 302. So congratulations. It's a huge achievement for the field.
Thank you. I think it's even cooler when your kids tell you that they saw something about pancreatic cancer on TikTok.
That must have been
that was
a
exciting.
Surreal moment for you.
Yes.
Very cool. How old are your kids?
My oldest is 22. But
wow.
They go down to 12.
Oh,
so
wow.
Teenagers, and they're really excited. They talk about this sometimes at home, so it's great.
So exciting. Okay, well, let's get into it. I have a lot that I want to talk with you about today. So pancreatic cancer, of course, at the forefront. It's historically been one of the tougher fields in oncology for a really long time. What drew you to it, and what have kept you in on it on the years, especially when the data weren't moving?
Yeah, it's a tough question. I'm glad you're asking it now that we have some really good answers. People asked this question of us last year and the year before, and the answer was a little harder. I've been doing pancreatic cancer for over 15 years, and I think what really drove me into it initially was just the tremendous need. The outcomes in pancreatic cancer are generally some of the worst of all cancers, and the lack of leads into how to do better in that were very apparent when I was even in residency and fellowship. I worked in several laboratories looking at drugs, and so, we had that sense that people desperately needed more therapies, and I was very driven to be part of that.
I love that. And you've talked before, and I think a lot of physicians talk about this in this field, about treating the whole experience of this disease, not just the tumor itself. Can you talk about what that actually looks like in a practice where for a long time we really didn't have good therapies to offer?
Yeah, we still obviously have a long way to go in pancreas cancer, as with many other cancers. I think that even when we didn't, before this great sort of new area of drug discovery, we certainly could help people who had cancer. And so part of the real focus is on humans and individuals, and looking at someone, understanding their symptoms and their limitations, and then using the tools that we have in order to help them. We're all frustrated that those tools are not better, but there are tools. And I would say that the most important thing in my career has been working with other people, so multidisciplinary care, and basically saying anyone who can help us in this fight should be part of the team. And so we've worked on creating teams and collaborations among surgeons and gastroenterologists and pain management specialists, nutritionists, geneticists. There's big teams that help us in our pancreas cancer care and can really help people.
Okay, I love that you're saying this, and I think it's something that we need to have more conversations with overall as a field, the importance of multidisciplinary care. You mentioned a few different really important specialties there. Can you maybe talk a little bit about how you find that all of you best utilize each other in these kinds of scenarios?
Yeah, it's like everything. It's always complicated when you involve many people. I think part of what's worked really well for us is focusing in essentially what we call a Pancreas Cancer Center and thinking of all of these specialties together, which doesn't always mean putting them in the same room together, but it means that they talk to each other. And so I think efforts to increase education and collaboration and teach from one group to the other about what's important are really, really what helps us do a better job.
Yeah, definitely. So we have to get into RASolute 302. This
brings a smile to my face.
Rightfully so.
Very exciting.
It's so exciting. And as somebody who was obviously a part of the trial and part of this really incredible team of investigators, at what point for you did it feel like, did it go from, this is a trial, we're running a trial, to, oh wow, this might actually change things?
Yeah, it's a great question, and it's just great that we could think about this, to be very honest. I do a lot of I run and participate in a lot of clinical trials. And one of the frustrations in pancreatic cancer has been that we've made really great discoveries in the lab and found things that were really cool, discoveries that led to drugs and then led to trials, and very often those trials don't pan out. And it's frustrating. It doesn't stop anyone from trying, I hope not, trying more and continuing to do it. I think that the target, which is KRAS, has been well described, well known as sort of the culprit in pancreatic cancer for well over a decade. The exciting thing about this trial is twofold. One is that the drug seems to work, and that's really amazing. And the second part is that it works for a lot of people. And so I think the second part was even more surprising to us, because sometimes we found things that target a very specific population, and that's great for those people. But the exciting thing about the RASolute 302 trial is that it really included all patients with pancreatic cancer in what was the second line, and showed a benefit for that whole population. So the excitement that it showed help for everyone on average was really, really, to me, the transformative moment.
I was going to say, we've talked about over the years the BRCA mutations in pancreatic, which again, wonderful. It helps that subset of patients. But like you're saying, this is helping such a broader range, and really now anybody, well, I shouldn't say anybody, but many patients can come in asking, knowing that if they don't have a BRCA mutation, that could be an option for them.
Yeah, I agree. I mean, there's so much to talk about, and we could, about this trial and how positive it was, but I think the key thing to me is that the drug itself clearly seemed to work. I mean, we saw that. I was part of the phase 1 trials as well. We saw that right away. Like any medicine, it doesn't work without side effects, and it doesn't work for everybody. But the great thing about the phase 3 trial was the breadth of benefit across the whole population, which is just so exciting for our patients.
It really is. And now this hazard ratio, 0.4, that's a striking number to have on a slide,
yes,
especially at a conference like ASCO. What does that actually mean when you're having the conversation with the patient in your clinic today or tomorrow?
Yeah, I mean, I think, again, that number is really important. We don't generally talk so much about hazard ratios in the clinic or p-values.
Right.
We talk about them a lot outside of the clinic. But when a person is in front of us, I think, of course, their desire is not to be there, right? No one wants to come meet me and be told that they need treatment for pancreatic cancer. I think and that's a challenge, and it's an important part of what we do is communicating what the diagnosis means, unfortunately what they can expect, how we can help them, and what they need to know about pancreatic cancer. Once we've done that education, the question is, how do you treat it? And I think a hazard ratio of 0.4 means that this new therapy had essentially a 60% better efficacy in terms of how well patients did than the standard of care chemotherapy, which is remarkable. I mean, it's dramatically better. And as you saw the numbers, we sometimes quote the numbers. The numbers in the study were clearly almost doubling the overall survival of patients. And that means that this person is likely to get benefit, live longer if they can get this therapy.
So I feel like it's probably different for you because you were involved in the trial, but have you already had maybe colleagues from other institutions or even in the community setting saying that they now already have patients coming to them saying, oh, can I get this drug?
Yeah, so I think everyone has that experience. I mean, the news, as you said, is out there. It's on social media, it's in mainstream news, and it should be, right? This is the dramatic breakthrough in pancreatic cancer. Everyone is calling and saying, what does this mean for me or my mother or my sister or my colleague or the person who has pancreatic cancer? And I think this is where we're in early stages of this because we're just learning that. And clinical trials always look at specialized centers and very carefully selected and managed patients. And what we have to now do is get this to be applicable throughout everyone and learn how to manage the side effects, how to get it to people who's best for this therapy. And of course, we're waiting for FDA approval as well. But once Daraxonrasib is out there, once this medicine is out there, I think a large number of pancreatic cancer patients will derive benefit.
Yeah, absolutely. And now you've obviously been in practice long enough. You've unfortunately lost patients that you wish probably could have offered this drug to. Does the results of RASolute 302, does that carry more like a weight for you, or is it really pure excitement now?
So I would say it's closer to pure excitement. There's some tempering. Nothing is perfect, and this is certainly not perfect. But I think the scope of benefit and the fact that it's applicable across pancreatic cancer means that for almost all of our patients, this is going to be an option if they need it at some point. I think the caveats are really important, which is that this did not lead to cure. And that is still our goal, right? So, in fact, it wasn't something that led to even multiple years of survival for patients. The median was around 13.2 months in second line. But it's a huge start, and I think it's going to be relevant for a lot of people. And of course, we're already doing and thinking about the next generation of drugs and clinical trials and applications for how this can transform care.
Daraxonrasib, so like you said, it's already being studied earlier in the treatment course in combination with chemotherapy, maybe in earlier treatment lines. Can you talk about the other maybe possibilities? And if RASolute 302 is the floor, what does the ceiling look like?
Yeah, so this is really what's exciting, right? If you think that this is the floor and this is so exciting, what's next and what is coming? And I think it goes back to the fundamental reason why we think this drug works. It targets RAS mutations, and RAS or KRAS is mutated in over 90, maybe 95% of patients with pancreatic cancer. And so this is a really smart targeted drug. You're going after the target, which is wonderful because it means that potentially you can lead to tremendous benefit. Of course, the challenge is that cancer is very tenacious and very smart. And these tumors in people become resistant to this medication, some quickly, some more slowly, but almost all of them eventually become resistant. And it's because tumors find ways around it. And a lot of what I would say, as we go from the floor up to the ceiling, is really learning what those ways are. And so requiring understanding in people, we do this, of course, in preclinical studies, but what are the mechanisms by which tumors get around this? And then, of course, what can we do to block those mechanisms? And so we have several studies already that are ongoing that are looking at a RAS inhibitor plus something else, which might be chemotherapy, but could also be another targeted drug. And I think the ceiling becomes finding what those pathways are and targeting more than one pathway. And if you can do that, potentially we can control these tumors for many years. And obviously the best case scenario is that we can eradicate disease and cure some patients who have these cancers.
No, very excellent points. And I wanted to also ask you this too for both our healthcare professionals watching as well as any patients that are watching. Any kind of side effects maybe to be aware of with this treatment?
Yes, so the answer is yes, there are side effects, and as expected, any medication has side effects. This drug specifically causes ones that are different than chemotherapy because it's not a type of chemotherapy, it's a targeted therapy. The major ones we've seen are rashes, and rashes are very common with the Daraxonrasib therapy. They're manageable though, and so you have to sort of be educated on how to manage the rash, educate patients, educate providers. It's going to take a learning curve, which is something we hope to be part of because it's new, right? It's something different than chemotherapy. And so the rashes are important. There are other side effects, things like mouth sores or mucositis, some nausea, fatigue. But overall, I think we found in the trial that these side effects were manageable if they were managed aggressively. And so that's really important. Of course, as we go on and we combine this with other drugs, we'll have to learn about what side effects might come up. And unfortunately, there are definitely going to be side effects. These are treating a very difficult cancer. Our hope, of course, is that we can manage those side effects, we can figure out what they are, and that we ultimately can help people do better.
Yeah, no, I think you're absolutely right. Of course, it's a learning experience. It's a management strategy, and the more that these types of treatments, more novel treatments overall, getting used, and everybody gets more education on how to manage things like that. Yeah.
I would say one of the most I wanted to come across, the most exciting things is just, people are calling all the time now and saying, someone who previously had no other options all of a sudden has this option. Sometimes, unfortunately, it's not the right thing for that person, or they don't have as great a response as we hoped. But just having another option in advanced pancreas cancer is incredible. And as you mentioned, we want this to be the floor and then keep moving upwards.
Absolutely. Oh, great. Now, you've spent your career in a disease that, as we've said before, doesn't have the best options. It's had a lot of rough days in the past, of course. If a GI oncologist watching this takes one thing away, what do you want it to be?
So I'm gonna cheat and do two things.
But okay.
I think still the main point is that we treat people, right? We treat people who have cancer. We are optimistic that we have therapies. We want to make sure everyone gets whatever therapy is best today. But the real message is that this is an incredible breakthrough, and there are going to be others. Mm-hmm. This is it's not even the beginning, it's the middle maybe, but it's the beginning of breakthrough against RAS in pancreatic cancer. And I think that the future of treating GI cancers and probably other cancers is going to be dramatically different in the next 5 to 10 years, which is really exciting. And we invite everyone to be part of that.
Yes. Thank you so much. Congratulations again. This is just fantastic news for the whole community. So thank you so much. So are you ready to play a game?
I'm ready.
Okay, so
I don't know what it is, but I'm ready.
Get ready. It's going to be fun. So the name of today's game is called Breakthrough or Buzzword. It's only going to be a couple of minutes, and there's 5 prompts. So the premise is GI oncology obviously has a lot of exciting language flying around right now. So I'm going to give you a claim or a concept, and you tell me, is this a genuine breakthrough, an overhyped buzzword, or somewhere in between? So you get 1 sentence, no lectures. All right, number 1.
That's tough.
It is tough. Number 1, RAS-targeted therapy is the single biggest advance in pancreatic cancer treatment in the last decade.
That's easy. That's a breakthrough. And as we've discussed, clearly this therapy is dramatically positive and is a breakthrough.
Yes. Number 2, liquid biopsy will eventually replace imaging for monitoring pancreatic cancer treatment response.
So I would go with somewhere in between. I think liquid biopsies will definitely replace a lot of the imaging we do and give us information, but they won't be enough.
Number 3, combining immunotherapy with chemotherapy will be the next major advance in pancreatic cancer. Genuine breakthrough, overhyped buzzword, somewhere in between.
I would say overhyped buzzword. We have not yet seen clinical trials that showed benefit from immunotherapy and chemotherapy in pancreas cancer.
Totally fair. Okay. Early detection research will save more lives in pancreatic cancer over the next decade than any new drug.
So I would say that's somewhere in between. I think that the decade part of it is the tight part. It's going to take us longer to get those early detection tests to make that difference. Eventually, it will be a huge breakthrough.
I agree with you. I hear so many people talk about that, not to go off topic, but hear so many people talk about that. Why isn't there the types of screening like there's for lung cancer and breast cancer, et cetera? So that would.
So I think it will come, and it will be a bigger breakthrough when it gets there. I just think it's taking longer than people anticipate, and it will, and we have to be smart about that.
Yeah, absolutely. Within 10 years, metastatic pancreatic cancer will be treated as a chronic manageable condition rather than a terminal diagnosis.
So I think, again, that's somewhere in between. I'm going to hedge. we've made real breakthroughs, and we will have more in the next 10 years, but I don't think it's going to go away.
10 years sounds like a long time, but in research world, it's really not that long.
It's really not.
Yeah. Agreed.
But I hope to be proven wrong, and I hope to be part of that.
Yes.
So,
Well, thank you so much, Dr. Oberstein. This was amazing. We loved having you on the Moonlight Shift. We talked about a lot of great stuff today.
thank you so much for having me. This is really exciting, and thank you for helping us highlight it.
Oh, anytime. Thank you. Dr. Oberstein.